Hello everyone, welcome to the next session for the day, session on digital innovation, Middle East opportunities, challenges and path forward. Am I audible?
Yes.
Okay. So the Middle East is witnessing a rapid shift in healthcare driven by technology and a desire to modernize care delivery. From virtual clinics to AI-assisted diagnostics and connected health platforms, digital innovation is reshaping how care is accessed, delivered, and managed. So I'd like to introduce our moderator for the session, Dr. Galina Osina, a real-world evidence strategist and a medical doctor with over 15 plus years of experience across pharma, medtech, consulting. She brings a 360-degree overview of real-world evidence lying across global, regional, and local markets to create effective RWE and digital health strategies that accelerate data-driven healthcare. She has published on RWE topics, participated in multiple health policy initiatives. Next, we have Dr. Akram Bouchenaki. He is the CEO of Jameel Health, Abdul Latif Jameel's healthcare business, focused on expanding access to modern medical care and addressing unmet needs in developing markets. Akram holds a doctorate in pharmacy and has lived and worked across 5 continents. He brings over 25 years of experience in pharmaceutical and healthcare sectors, including global leadership roles in big pharma corporates as well as top California-based biotech companies. He was an executive director at Africa, covering the largest markets on the continent. Akram has an extensive knowledge and experience of both generics and branded medicines in established as well as key emerging markets across the world, which include Africa and most significant markets like Brazil and Mexico. Next, we have Dr. Ruth Jacob. She's a distinguished leader in health economics and outcomes research, market access, and reimbursement strategy. With over 15 plus years experience driving successful product commercialization across multiple therapeutic areas and geographies, Dr. Ruth has launched 15 products in both US and EU, shaping clinical development plans, leading HTA submissions, and delivering evidence generation strategies that secure payer and stakeholder alignment. She has held senior leadership roles at Sanofi and now serves as HEOR lead at Cepheid, bringing deep expertise in clinical outcomes assessment, value-based pricing, and health policy. We have Sophie Smith, founder and CEO of Nabta Health, a hybrid healthcare platform transforming women's health by accelerating detection, diagnosis, treatment of chronic diseases in emerging markets. Prior to founding Nabta, Sophie worked at Accenture as a technology consultant and then founded several impact-driven enterprises, including Maya Zindagi, a doctor finding platform based in Pakistan, and Lee Plastics, a plastic cycling company based in Sierra Leone. With that, I hand it over to you, Galina, to take it forward from here. Welcome you all.
Thank you, colleagues. Dear audience, greetings to all of you. Thank you for being with us today. So, digital health in the Middle East. It has seen unprecedented growth over the past years, significantly driven by the COVID-19 pandemic. Defined by WHO as a systematic application of information and communication technologies, you might have heard the term ICT. It was initially aimed at improving access to care, its quality, reducing efficiencies, reduce costs, and at the end of the day, to improve personalized care and in general provide a better care for patients. How big this initiative is? Just so you know, WHO has kicked off the digital health strategy of 2020 to 2025. Now, it is extended to 2027. And this strategic document served as a lighthouse, as a roadmap for the other 190 countries, which have in turn elaborated their own digital health strategies. Middle East didn't stand aside of this healthcare transformation, mainly looking to diversify the oil revenues. Historically, a very digitally savvy region, which we can judge by the rate of adoption of mobile phones and smartphone technologies in the region. It has demonstrated that it is completely in line with the global trends. The current digital health market in the Middle East amounts to $10 to $20 billion, estimated by different agencies. It is about 5 to 10% of the USA one, just to give you a benchmark. But the CAGR, the annual growth rate, is estimated to be at 22-23%. So imagine that by 2030, it can catch up with APAC region, which is now 7 times bigger. So if we look at the landscape of countries in the region, the two leading countries in digital health adoption is UAE, United Arab Emirates, and Kingdom of Saudi Arabia. Mainly driven by the two countries' national initiatives kicked off that we're going to be covering just in a few minutes, with Qatar, Kuwait, and Oman catching up and holding the huge potential in having those technologies spread rapidly in the upcoming years. Digital health is high on the agenda on both above country and national levels. If we look at the above country level, on the level of Gulf Cooperation Cluster, the GCC, we will observe multiple alignment initiatives in terms of policies, AI adoption, and the general development of the digital infrastructure. And the national initiatives have been kicked off by several biggest markets in the region, like UAE, Saudi, Bahrain has also done so, Kuwait has also done so. And within these national programs that encompass, bigger healthcare initiatives, within those healthcare programs, there have been digital platforms kicked off, like Riyayati in the UAE and Cepheid in Saudi. These are not purely electronic health records capture systems. These are the broader ones. This is also to make medical appointments, also serve for telemedical services. But most important is that those platforms were able to unite data coming from public and private segments. And this has been a historical challenge in the region, and not only in this region. I'm coming from the other region, and I can tell you that in my country of origin, it's the same. It's difficult to combine data coming from entities of different origin. So Riyayati integrates in-turn data coming from electronic health capture systems like Malafi. Akram will walk us through this in just a minute. And another platform, which is hosted in Dubai. And altogether, it brings us to almost 100% of population coverage. Why we are talking about this? Why is it important? Because the more national data we have, the broader opportunities we have for research, including real-world evidence research. We'll go on this with Ruth and Sophie in also just a few minutes. What I would also like to mention here in this overview section is that such digital platforms are a good example of public-private partnerships. This is one of the critical success factors of driving digital health adoption in the region. For example, Malafi, that we have just mentioned, this health information capture system, is a good example of how Department of Health in Abu Dhabi Health Data Services and vendors can work together on accelerating electronic health records implementation. Another really big public-private partnership is Saudi Vision 2030. It has originally been launched in 2016 and is now a good illustration of how Ministry of Health, Saudi Data and AI Authority, academia, and the global vendors like IBM, like NVIDIA can work together on driving healthcare innovation, AI adoption, genomics, and value-based care. We'll just look closer into this just shortly. And last but not least, in this intersection is real-world evidence. It is very strongly interconnected with digital health, not only because digital health is a strong supplier of the data, which is further used for research. On the other hand, real-world evidence is a good way to inform and accelerate development, scaling, and optimization of the digital health technologies. The hospital model, which has been introduced by Nabta Health, mainly in UAE and Saudi, integrates digital and in-person care in women's health segment. And this is what Sophie will just walk us through in several minutes. Before we go to the discussion itself, to make this discussion a little bit more interactive, I'm asking the organizers to launch a poll now. Let's put it on the screen. And with this poll, we'd like to check the average temperature in the hospital. So once it is there, you will see. So can we get the poll, please? Yes, so giving you about 1 minute to answer. So we are interested to see where you think your country currently stands with digital health implementation. This is a multiple choice selection. So if you know that in your country there are some national programs launched, or there is a healthcare workers preparation program, or there is a stable investment in the space, you can click several. And we see that the leading items are national electronic health records and stable investment in the space. Almost 30% people voted. So let's vote. Let's be more active. We need to landscape. We need to check the temperature in hospitals. Let's wait 20 more seconds. The overall picture is clear. So not all countries, from what we have seen, not all countries have launched their digital health strategies. And that means that the leadership should also probably be more supportive in this space. And again, let's say again, did anything change here? Oh, it was launched again as far as I see. Okay, let's give people a little bit more time to vote. Colleagues, multiple choice is possible. Oh yeah, so it's again electronic health records leading. Okay, it changed. National digital health strategies launched, and again stable investment. Good. This is what came expected. And now let's give the second question, and the last one. So let's quantify it. Let's get closer into figures. If you take the scale starting from 0 to 100, your country digital health maturity level, where do you think your country ranks? For organizers, let's please kick off the second question of the poll. Yeah, so here it's a single choice. So you need to select in which of the 4 baskets you would like to put your country digital health maturity. And it would be interesting to see the results. In the previous question, we understood that there are national digital health strategies launched, and electronic health record systems are built or are being built. Investment is stable. We didn't observe much that digital health services work well across areas, almost nobody voted for it. Neither was the curriculum for healthcare professionals. And this is an important gap because at the end of the day, these are the people who are supposed to work in this space, who are supposed to propagate this space at their routine life. And advanced technologies was also not so well developed. Good. So can you please look at the results? Can you please put the results on the screen? It's just interesting to observe who voted for what. Remember our audience. Just curious if you were able to pass the 50% benchmark or not with the maturity. Of course, there are international digital indexes. So what I like is Digital Health Monitor. It has been launched by WHO several years ago, and there is basically a world map, and you can click on your country, and you can see the level of development of several strategic digital health areas. So wherever you are in India, in China, in the US, you can just click on the map and you will see how your country is assessed to develop in key strategic areas. Okay, folks, for time's sake, I suggest we move on. And the first question, Akram, I'm looking at you, and the first question goes to you. So building the bridge, what we have started with, Malafi. So from your perspective, you have a rich experience implementing these kind of initiatives. You've been working with hospitals and with other important stakeholders on the region and above regional levels. So what are the improvements of patient outcomes that have been brought by initiatives like Malafi and Cepheid Virtual Hospital?
Thank you, Galina. And again, pleasure to be among such an esteemed panel and part of a great program as the one of this evening. So a great question about patient outcome, because at the end of the day, all these improvements in technology are supposedly bringing improved patient outcomes. And I think that's going to be the end of the journey. However, important to realize, so I started my career in this industry 30 years ago. So I've seen a lot of evolutions and across many countries. And so what we are observing is obviously a trend towards the gradual adoption of technology in healthcare, and particularly in instances of electronic health records, an initiative like the one that has been implemented in the UAE under the name Malafi, which means my file in Arabic, is a really good illustration, because what it did is it created a unified place for all the patient information, where it integrates data such as lab results, radiology imaging, allergies, historic past medication, procedures, immunizations, etc. So it's extremely helpful. First, it combines the information, so it's good for the patient to have his information in one place. It avoids for healthcare systems what we often see, unfortunately, which is patient nomadism, where a patient will go and ask for the opinion of 5 different healthcare providers, wasting resources, getting extra useless exams. So all that cost that could be used otherwise. And so I think that's the first level benefit that people can get by implementing a unified healthcare record system. And many countries are doing it. Malafi is a good example, as I said, but Saudi Arabia is doing the same. Egypt is implementing the same, which is a huge task on a large scale population. Obviously, it's easier on a smaller scale population, but these are very important steps to be taken by healthcare systems. Oh, you're on mute, Galina.
I'm looking to consult 5 different doctors. This is exactly the system that will help you see all the records that were obtained in 5 different healthcare settings. Ruth, a follow-up question to you. So many countries have already built or are building their electronic health records capture system. From your point of view, what is the transformative potential of having EHRs digital? And what are the challenges in integrating such a technology in the traditional healthcare setting, which used to use paper-based medical records?
Yeah, no, thank you. First, the way I see it is when you look at electronic health records, that's the foundation of the digital health tool, right? When you move from a paper-based into the electronic health record, that becomes your foundation. On top of that foundation, you can then start building it. Why is this foundation important? Is that when you use real-world evidence, that is technically what your electronic health record is. It's not part of your study. It's not part of any randomization. It's what happens in a real-world setting. So when you have such real-world evidence, the reason it becomes transformative, or it has a transformative potential, that this real-world evidence in the form of the electronic health record. Am I echoing? Or can you hear me okay? Yep, good. Okay. So the reason why it's transformative is because it captures systematically a longitudinal patient data. To Akram's point, it could be diagnosis, it could be treatment, it could be lab results, patient outcomes, whatever it might be. It captures it longitudinally in a very systematic manner. And the reason why this becomes transformative is that you can look into the data and you can see at a population level. When you start seeing at a population level, it provides insights into disease patterns, the effectiveness of the treatments, and what are the gaps that exist. And then it also becomes informative and transformative is because of the use of AI. It starts predicting the risk and what kind of these clinical decisions can be. And these are the factors that makes it more transformative, right? So that's on the transformative element. Now, the second question I had is around the challenges. What are the challenges it has? Like every electronic health record, which is not very far from the paper record. So from the paper, it kind of then moves into an electronic system. Like how the paper has incompleteness, electronic health records also end up having incomplete data, right? People is unstructured. People just write notes in electronically. So then it becomes an unstructured data. Clinicians or healthcare professionals do not fill in the data, then it becomes the missing data. So the kind of the data quality and the lack of completeness is a huge challenge, right? So that's one thing. The second thing is, how are you going to navigate the security concern, the privacy concern, the governance issues, the consent, every kind of patient data protection, it's a complex problem. So all these are like very high level challenges that these electronic data record possesses. But I think people are moving towards how best we could address these challenges, which is collaborating across different stakeholders, like bringing in clinicians, regulatory, and patients. When we start addressing it in a collaborative manner, then we could build in systems that tackle these challenges, right? So if you have a regulatory stakeholder along with the clinicians, then the issues of concern, the security, privacy can be taken care of because you have a governance as part of the regulatory involved with the clinician. So that is how you kind of, build a system that is able to address these challenges. But digital health, especially the electronic health record, will be the foundation, and it is transforming the healthcare delivery, not just in Middle East, but across the globe.
If I may add to what Ruth just said, I think it's a critical piece because it's the practical transition from the theoretical concept of a unified health record system to, how do you make it work? How do you make it sustainable? How do you make it useful and consistent? And I agree with you completely. The data gaps are an issue, and the quality of the information entered. But I also believe that technology is going to be helpful to solve for many of these issues. There are companies, for example, I met a company out of India called Raxa that basically summarizes a consultation into simple, actionable, recordable tracking that you can use in the patient's record. And so you make it consistent that way. And it's the same way for the flow of lab information, of imaging. So that I think technology will, in the short term, make it much more functional.
Yeah, true. Just to give an example for that, the example that I'm facing is because I'm in the diagnostic world. The AI in diagnostic, what happens is software updates, right? The software updates are very frequent, and the regulatory bodies can't keep up with it because of the frequent changes. And these frequent changes means that the regulatory bodies are struggling to keep up with the speed. So that's an issue, right? So even if we come up with an very important AI diagnostic in a digital health tool, which is going to revolutionize things, but such software updates are so frequent that that adaptiveness of a payer or a regulatory is really lagging behind. And so that brings in delays to the adoption of innovative technology as well. So I think even though the AI is bringing in the rapid changes, there's still a bit of lag. And that is also a challenge. The speed is also a challenge.
Such an interesting discussion. Colleagues, any thoughts? Can we do anything regarding this fact that the technology is developing much faster at a faster pace, that the environment represented by regulators, the payers, so people who authorize the technology or then reimburse it, really do not keep up with this pace. Can we from our side, as an industry, as academia, as representatives of medical community, what can we do about this? If we could, just a quick thoughts.
Is a question for me?
No, it's for
Maybe I can take the question, right? So for me, like talking from a payer's perspective, the kind of the area that I'm in, there's one thing about speed and having AI-driven tools or having patient data, right? When you look at effectiveness. But what payers need is long-term outcomes data, right? And how can we get the long-term outcome data? In order to get a long-term outcome data, the frequent changes that I mentioned, right? The frequent software updates and changes could be a bottleneck for long-term data. So what we really need is a very good balance of innovation, right? An innovation which is not just a fast innovation that brings in, addresses complexity, but a fast innovation that is also stays for a longer period of time, because it's a long-term patient outcomes data is what a patient needs. So the question is, how do we really build digital tools that are there that addresses the reimbursement bodies? That is the kind of, the difficulty that payers are facing, because they can see there's a systematic challenge in the framework of how these digital health technologies are evolving. They're evolving very rapidly, but they're not evolving long term. That's one of the risks from a payer's perspective.
I think as long as you have provider-led centralized models of care, as the pace of technological advancement increases, we're going to struggle with data management to keep up. If you decentralize care and enable patient centricity in terms of data ownership, then in theory, the technologies, the tech stacks and the integrations of the payers or providers can change as often as they want. It won't matter, because the data ultimately will sit with the patient, and the patient will carry it with them their whole life. And as and when they're required to input it into a new system, they'll be able to. And so the data will start and end with them. I think if you want to add a kind of a layer of immutability, then you introduce things like consortium blockchains, where every time there is a transfer of data, you stamp a decentralized ledger, and that becomes the place where patient data, if it doesn't live, it is at least validated. So I think as the pace of technological advancement increases, decentralization of data ownership and permissioning is going to become more and more key.
Awesome. Thank you, Sophie. Akram, anything from your side?
I think just to follow up on the previous point you were raising, Galina, the question about who will be ultimately paying for all of this and how to ensure that we don't create a gap in access to digital improvements, because just like we see in the gap in access to modern therapeutics based on affordability, how do we not replicate what has happened on medication on the digital space? And that would be a challenge. So far, it probably sits on government's shoulders, and all the initiatives we mentioned have been mostly funded by governments that are pursuing a vision of universal healthcare and coverage, etc. But then what happens when government funding dries up, or there are other priorities, or there are countries that cannot afford the same level of investment? I guess that's a question. I don't have an answer to that.
Yeah, maybe this is where value-based models can come into play. Okay, let's move on. So, Sophie, women's health, it's an important segment. And historically, women's health has been underrepresented in clinical trials and health records. From your perspective, how can AI-driven diagnostics and EHR systems help close these gender gaps in the region? And you're a founder and CEO of Nabta Health, so what role does Nabta play in this?
I think I will address the EHR role, then the diagnostics role, and then discuss Nabta at the end. So from an EHR perspective, there are very basic things that can be done in terms of introducing standard operating procedures for areas of women's health that have historically not been served. To give some context, women were excluded from clinical trials until 1993 globally, which means that today women are still significantly more likely than men to suffer adverse reactions to drugs and to suffer worse health outcomes. For example, it takes 4 times longer on average to diagnose women with the same chronic conditions as men, even though they're twice as likely to see a doctor in the first place. There is an issue with CPR and women being less likely to be resuscitated because all of the mannequins that are used to train paramedics are male frame. They don't have breasts. And so paramedics or people performing CPR on the street are less likely to resuscitate a woman because they don't know what to do with the figure in front of them. Until about 2 years ago, we thought that the symptoms that you experienced as a woman suffering a heart attack were the same as the symptoms of a man. Galina, if I asked you, what are the symptoms of heart attacks in women, what would you say?
Acute pain, short of breath. I would say like the same as in a human being.
Yeah, so sorry, I put you on the spot. But in men, it's a numbness and tingling in the left arm and a pain in the chest. In women, it's extreme fatigue and nausea. So actually 2 very different sets of symptoms. And until recently, we didn't have a clue that that was the case. And if you don't know that there are differences in terms of symptoms between men and women, and you can extend that line of thinking to everything, to protocols, clinical pathways, therapeutics, it's difficult to ask the right questions and therefore to generate and document the right data. We were engaged recently by the Ministry of Health in Jordan to support the rollout of menopause care across 630 public primary healthcare centers. And that actually meant a lot of very basic things, such as introducing a kind of standard operating procedure for menopause care within clinics and a bunch of questions that your general practitioners and family medicine specialists would ask women between the age of 30 and 60 if they came in to understand whether they could potentially be in perimenopause. So in the first instance, bridging data gaps is acknowledging that they exist and then looking at the health records and the kind of clinical pathways that we have for women and trying to work out if they need to be different. In terms of AI-powered diagnostics, one of the significant benefits of machine learning and AI as an extension of that is pattern recognition. As human beings, we have within ourselves more inherent prejudices and pattern bias. It's difficult for us to kind of supplant our own way of thinking or to acknowledge and to recognize when people are coming in and they're asking us the same questions and we're ignoring those questions and we're treating them in the same way. Artificial intelligence is better at recognizing patterns and disrupting them. And so in the first instance, what AI diagnostics can do in a clinical setting and in very basic ways is identify patterns of behavior among women and again, initially highlight some of the gaps. In terms of Nabta and what we do, we operate a vertically integrated ecosystem for women's health in the Middle East and Africa with the mission of closing the equity gaps that exist in healthcare in the region. And that actually for us starts with identifying where at every level these data gaps exist.
Yeah, awesome. So for cardiologists and emergency care doctors who are watching us now you know about the systems.
I sincerely hope that cardiologists who are watching this presentation knew about the difference in symptoms of heart attacks between men and women. I would be very concerned if they did not.
Yeah, awesome. Cool. And building a bridge forward a little bit regarding Nabta's role. So your company has elaborated and operationalized the hybrid clinic model, which integrates the digital and in-person health services for women. So could you elaborate how real-world data and subsequently evidence that can be generated through such a model can transform women's outcomes in the region by 2030?
Okay, I think there are many ways that I could answer this question, but the shortest answer is it gives women back their time and their money. Women are responsible for 80% of consumption decision making and 80% of caregiving globally. There is a huge amount of shame and stigma across the globe, but particularly within the Middle East and Africa, attached to symptomatic care, which is the healthcare system that we have today. You identify a symptom, think something is wrong, you go and see a doctor. If we are able to preempt through a proactive subscription-based model of care, this stigma and shame that is attached to symptomatic care. So we're able to proactively engage with women at a goal stage, ask them about likely symptoms, map out care pathways, plans, and teams for them. And then we're able to provide access to all of these things in places where women are. And for a fraction of the cost, we give women back their time and money. And with more time and more money and healthcare on their terms where they need it, women can do more. They can live healthier, happier versions of the lives that they were meant to have.
Yeah, so it's not mainly about medical outcomes, it's also societal value, big societal value that.
Yeah. I mean, it's health outcomes as well. So with our subscription-based model of care and with the companies that we work with, we have an annual health check or preventative screening rate of 40.4%, which is 4 times the regional average. In 96.9% of all users, we have a new or revised diagnosis. So the model of care that we have is much better at picking things up early than traditional healthcare, which is in the way that it is built, designed to be reactive. So I think there are significant opportunities in terms of improving health outcomes with a model that is proactive and prevention focused. But yeah, from a societal perspective as well, understanding as we do the differences that exist in terms of expectations and access for women around the world, the model we have is opportunistic in that sense too.
Yeah, cool. Cool. We'll come to the outcomes also in the end of the discussion. And now, Akram, from emerging hospital model to emerging technologies. You have experience working in different regions, and could you please share with us what's the role of emerging technologies like genomics in MENA digital health future?
Yeah, so I guess next to the diagnostic space, the obviously now genomics is becoming almost routine, although again there is an access barrier. Let's just recognize it. It is an expensive technology still and not available everywhere. However, where it is available, when you look at the genome mapping initiative that is happening in the UAE again, very interesting, looking at mapping 1 million citizen and looking at their genome, or the mandatory premarital genetic testing that looks at 570 genes and that link to about 800 or 840 different diseases. So these kind of initiatives are obviously extremely impactful at the end of the day. So we, for instance, commercialize medications for rare genetic disorders. And so when obviously you know what the problem is and you have a solution, a therapeutic solution, it obviously helps at the end the patient outcome. And I think that's really the name of the game, when you can marry a large public health initiative with therapeutic options are available for severe debilitating diseases, then you have a kind of a winning recipe. But it takes a huge amount of effort and investment. And again, we go back to the question we were raising earlier of funding for all these initiatives that are at the end extremely costly, but that have massive and deep and long-lasting impacts on populations.
Yeah, cool. And just a quick question that just popped up in my head. What do you think having a registry of rare disease patients on the national level, will it plan the healthcare authorities, plan the budget, plan the care provision for these patients? Because such initiatives, like I know in Europe, they are life and money, mainly in certain disease areas. So what's your take on it?
Registries, definitely when they're well organized, well documented, with good quality data, to Ruth's earlier comment, they're immensely helpful, whether it be for infectious diseases, for cancer, for rare diseases. It is a hugely helpful tool for planning, for resource allocation, for ensuring that you have the proper armamentarium, again, as a healthcare system to address these points, and then helps planning forward for resource allocation. So no, I'm all for it. What we also see is a lot of individual hospital level type of cohort studies. And I think with technology, these probably will start to aggregate and start to have a bigger and bigger significance and impact, hopefully.
But I think one thing with the issue with these registry is that mostly if you look at the registry, rare disease is a classic example that Akram is mentioning. It is a requirement. It is a regulatory requirement to have a registry as a part of a post-marketing requirement. When it becomes a requirement for post-marketing purposes, then the data is available maybe for the regulators, for the payer, and the company who's sponsoring such a registry. Then the data is tied within these three parties. If somebody is thinking of integrating that data as a real-world evidence, then that data is not available. So it's a question of, when we talk about digital health tools and when we say real world evidence is a foundation of the digital health tools, it also depends upon the availability of such data. And mostly these registries are data that is only available for the manufacturers and the governance and the regulatory bodies who's regulating the whole process. It's not available, at least in the way it has been set up, for anybody who wants to integrate the real world evidence together. Then how do we know the gap? How do we know what is required to improve the patient outcomes or to kind of, change this health model? Then it continues to be a gap in spite of having registries available.
Absolutely. So it's one story to have data available, have it accessible, have robust evidence in place, have acceptance in place. So a certain best practices Okay, this practice does emerge. So the number of cases when the molecule has been authorized or granted reimbursement or reassessment is growing, but it's still we are on the way. And Ruth, it's good that let's continue with you. So we have spoken about AI, so we touched upon it. What's your take on how can AI and machine learning enhance clinical decision making and with that improve the patient outcomes? So if we turn back to technology, what's your take on it?
Yeah, because the beauty about machine learning is that it allows us to identify patterns and risk factors, right? When something allows you to identify patterns and risk factors, then you can continue to break down the data to improve efficiency. And you look at an intervention, you look at a new model, and you can say, okay, I can use a machine learning to see if this new data which is something coming from the digital health solution. Can this new data help me to change the clinical guidelines? Does this new data that I have generated using machine learning, is that helps, in emerging evidence? Therefore, this new emerging evidence can be fed back into a clinical decision model and therefore change the clinical guideline. So it kind of helps you to be very proactive, right? So previously, before AI, I would say the decisions were very reactive. You have a problem, and then people start looking at it. But now, the technology, the digital health, and AI really enables people to accelerate the decision making in a proactive manner. So by doing that, you can make your decisions, which are very informed decision, not just doing a decision because in a knee-jerk reaction. These decisions are very informed. You are able to reduce errors because you're making a decision based upon data, new data, data that is adapted to meet your requirements. And collectively, this really benefits patient because end of the day, any data that improves your decision making, reduces error, brings in better health outcomes for patients.
However, I would put a slight angle on this, Ruth, in the sense that the healthcare provider and the healthcare system need to be ready and equipped to actually be in that position. It's a change of mindset. It's quite a deep change. I'll give you a concrete example. One of the philanthropy of the Jameel family is called Jameel Clinic at MIT. They develop artificial intelligence tools in the healthcare space. One of them is a predictive tool for the occurrence of breast cancer. That will be actually that might interest you in the space where you are, in the sense that it is a tool that uses machine learning and artificial intelligence, looks at a mammogram and then can predict with a high degree of certainty the risk of occurrence of a breast cancer 5 or 10 years down the road. And so then the question becomes, so what do you do with the information, right? You're a healthcare provider, your patient comes to you and say, what do I do with this risk factor? And so I think you need the healthcare provider and the system more generally need to be prepared to absorb and create a pathway and a patient journey, or actually not a person's journey, because they're not patients yet, but they have this Damocles spade on their head, and so you need to actually. I thought this raises a number of issues that need to be thought of and addressed ultimately.
Yeah, and I totally agree. I think what we are seeing now is there's a lot of accelerated, evidence using AI, but everybody is working in their own silos. What we need is an integration across silos, right? When an institution is coming up with a new technology, then how does how these different people and the teams are coordinating together? I think the kind of a feedback loop or a loop of there is an institution with a technological advancement, how it is coordinated, and if they're able to remove that hindrance and coordinate together, I think that's the kind of the next chapter in success. I think that's what we would see. Maybe maybe a couple of years from now, maybe kind of integration across these silo working could be the next chapter for success.
And maybe back to the initial topic we were discussing, maybe the unified electronic health record may be a tool to help integrate the information and use and allow for the exploitation of the information in a positive, rational manner to the benefit of the person and the patient.
Yeah, we're having a very interesting discussion. So I'm very, very happy to listen to you guys. And coming back to technologies, which are often born in a smaller startups, so like fast-paced companies. And I have a question to Akram, you and Sophie, because you have this entrepreneurial experience. for you, what would be a sustainable business model for digital health startups in the region so that they continued to provide those digital health innovations that in turn will be then funded by governments and at the end of the day be this fuel for subsequent adoption of digital health in the region? What would be your take on it?
Sophie, please.
I think the primary consideration for any company that is looking to build a digital health startup is who, at the end of the day, is going to be paying for it. In the United Arab Emirates, for example, the primary payer of care is not the individual or even the government, it is companies. We have an Emirati population that is approximately 11% of the total UAE's population. There are different health benefits provided to the local Emirati population, but for the expatriate population, which is the majority, it is companies or the sponsors of your visa who are mandated by law to pay for your health insurance. And it's a funny old thing in the UAE whereby people will pay or spend a fortune on anything wellness related, on gym memberships, on fitness, on cosmetics, on saunas and ice baths. As soon as anything is in the healthcare space, they expect it to be covered by insurance. So if you have a digital health startup that is providing more efficient, low-cost access to blood tests, for example, or you offer some home healthcare options, or you have some AI-powered diagnostics, or you provide virtual consultations or access to a multi-specialty team, whatever it is, the only way that you are going to be able to get a decent amount of traction and become financially viable is if you find a way to sell into the primary payer for care, which means either selling directly to companies via, to micro SMEs, SMEs corporates, or via insurers, brokers, and TPAs. And the same consideration has to be the primary one in any market you go into. Identify the primary payer of care. Is it the individual? Is it companies? Is it government? And adjust your business model accordingly.
Yeah. Akram, if I might ask you to wrap it up to like shorter, so that we could have some questions from the audience. We have
Completely agree with what Sophie just said. I think that's the 90% of the problem is that one, the funding question. The rest is all basic prerequisites that you need to make sure you have in terms of interoperability across systems, privacy, etc., which are the basic norms. But funding remains the core question, and I think it's true in the UAE, but it's true in many other territories as well.
Yeah, awesome. We're having a great time, but in the meantime, our time is coming to an end gradually. We have two questions in the chat. The first one, and I would like to address it to the panel, are regional collaborations, for example, GCC, helping create unified standards for digital health in the region? I think it's a great question.
Yeah, really good question. Sophie, you're saying something?
Yeah, we need to look at in the UAE having a federal or at least emirate level health record requires then some standardization across the third parties that integrate with it. I think whenever there is a policy change, it results in improvements from a standardization and an access perspective overall. And this doesn't just apply to the digital health space. So, for example, in the UAE, we have the Essential Benefits Plan. There are three different EBPs. So one under the Ministry of Health and Prevention, which governs the Northern Emirates, one under the Department of Health in Abu Dhabi, and one under the Dubai Health Authority. But they're roughly the same, and it's a basic set of benefits with a cap of between 50 and 150,000 dirham that every insurance provider has to provide. For example, basic maternity cover, some support for cancer care, like oncology, etc. Every now and then, and it happened at the start of this year, the Essential Benefits Plan is updated. For example, this year there were some dental that was added to the EBP and some mental health allowance as well. And when that happens, every insurance provider that operates within the country is also required to update its table of benefits. So it provides these as standard with some minor modifications to pricing as well. So it's an example of how, when the government leads from a policy perspective, we see improvements in terms of access and standardization overall. And for sure that is happening, and it's happening on a more regular basis. And we hope, again, definitely here in the UAE, that increasingly it will happen on a federal level. So we'll see updates that unify things, not just within Emirates, but across the whole UAE.
Awesome. I think we need to wrap it up. We have one more question in the chat, but unfortunately we do not have time to take it. So wrapping it up, it's been a good journey so far, and still a lot for us to go. And it is important to have this government or central ask, like central leadership that Sophie has just spoken about. Technology is another critical success factor. And the third, like it is my personal takeaway, a collaboration between different categories of stakeholders all together can help drive digital health and real-world evidence forward. Thank you so much for this productive discussion.
Thank you all.
Thank you.
Thank you.